Hi, I'm Barry Trachtenberg from Methodist DeBakey Cardiology. I'm very privileged to have our guest speaker today, Dr. Martha Grogan from Mayo Clinic, Rochester, and she gave a wonderful lecture on amyloidosis, cardiac amyloidosis, in which she's a worldwide expert, and we're very privileged to have her here. So welcome, thank you for being here.
It's great, my pleasure.
So Dr. Grogan, if you could tell us about your career path into medicine, how you came into medicine?
Yeah, that's a great question. I think like a lot of people, I was interested in science. I was a biology major, but I was always just probably more interested in anatomy, physiology, and maybe for some of the younger people looking out, I didn't get in the first time or two. I applied to medical school, but eventually had a lot of options, and then went to Northwestern to medical school.
Great. And did you, in terms of cardiology, is that your first?
That's a great question too. So again, medicine, I thought, I love science, but I really truly did think I wanted to do something that would help people and where I'd be interacting with people a lot. I really liked general internal medicine a lot. Actually, when I was in medical school, some of my colleagues would kid me that I liked every rotation. And they'd say, well, you can't talk to Martha because she likes everything. She thinks everything's great. I go, well, I thought you probably should like most of your rotations, right? But so I liked them all, but I didn't really see myself as a surgeon, some of the other options. So some type of primary care or internal medicine interests me. So I was very interested in internal medicine, but I always had this interest in cardiology that kind of stayed with me.
Yeah, well, it's good with amyloid to know all the organs, certainly helps. And
that's actually true.
Background.
That internal medicine background really does come back to help me a lot. When I was doing internal medicine residency training, I noticed that when I was on, after I did cardiology, that even if I was on another rotation, I was spending all this time on the cardiology physical exam and reading, and thinking about the cardiology differential diagnosis. But I might be on pulmonary, and pulmonary, I just wrote lungs clear. I thought, well, okay, maybe this is a sign,
So you've had a very interesting career. So you started out adult, I don't know if everyone knows this, but adult congenital heart disease and a lot of echocardiography. And then amyloid became more and more of a passion over the past decade. Is that?
Yes, yeah. So I really liked echocardiography and heart failure. I was always interested in amyloid. We have a lot of amyloid patients at Mayo Rochester, so I saw them during my residency and fellowship, and I had done some research projects in amyloid. And so I spent some dedicated time in heart failure, but then I did a year of adult congenital heart disease, which that was really fascinating to me because when I was a medical student, I loved pediatric cardiology. But I just didn't see myself taking care of pediatric patients. And I did not know there was such a specialty as adult congenital heart disease. So when I found out about that, that was kind of a great, marriage of my interest and with echocardiography. And then I still could continue my heart failure interest. So I did both, a lot of heart failure clinic and adult congenital heart disease. But in the heart failure clinic, I would be seeing amyloid patients. And then in recent years, when we've recognized that amyloidosis is not so rare, I started to see more and more amyloid patients, and then that was keeping me so busy that I felt like I couldn't focus as much on adult congenital heart disease. So I still have some congenital patients, especially ones I've seen for many years, but my new patients now are almost all cardiac amyloid, which is pretty amazing.
Yeah, well, I mean, what drew you to that? I mean, it was such a rare disease, and we had almost no treatments until recently.
Yeah.
And I know you've been driving this field in terms of doing clinical studies, but 7 years ago, 8 years ago, when you were starting your clinic, I mean, for AL we had chemotherapy, and
Yes.
it wasn't as good back then. And TTR we had almost nothing. So.
I think it was a combination of that, it's hard to know why one subject interests somebody and someone else who might seem quite similar aren't, they aren't as interested. So I think I just found it fascinating. And even though AL can be such a tragic disease, I started to see patients that were doing better, and I recognized the early diagnosis. So that just kept me interested. The cardiac amyloid clinic per se, we were finding that even though we had most of our heart failure specialists were very familiar with amyloidosis, still the hematologist would send the patient, and often they would get put on routine ACE inhibitor or beta blocker. Then the hematologist would be in a difficult situation of having to stop that. So I thought we really need to focus. We need a core group of people. We actually just had one virtual clinic appointment per week in 2012. Now we have 4 half days a week that we see cardiac amyloid clinic patients. Yeah. In fact, one of my patients said to me a few years ago, "Oh, Dr. Grogan, do you only see patients with cardiac amyloidosis?" And I was just shocked that they said that, but that is most of my practice now.
It's incredible to think of where the field is now, and I mean, you go to heart failure conferences and American College of Cardiology, and it's such a sexy topic, and there's new drugs, and everyone's talking about it, and there's such an amazing interest in this field now. I mean, could you imagine that when you started this?
That's hard to imagine. Yeah. And the really gratifying thing is that in both AL and TTR, now we have treatment. The AL amyloidosis patients, as you know, are now, even some that you really think aren't going to make it, they're responding to chemotherapy, and they're surviving longer. And then to see the TTR patients now have a treatment option, it's really exciting. I think one of the things for people that are thinking about a career choice, I mean, you have to do something you're interested in. And then with amyloid, it turns out historically most cardiologists didn't really want to see the amyloid patients. Even now, I would say there's not a huge, not a lot of people banging down the doors to want to necessarily see them because they're complex and challenging. But so for me, it was just a combination of interest, and then all of a sudden the field exploded at the same time.
Did you have any mentors at the clinic that were doing amyloidosis, or really no one was doing it?
Well, actually, we had a really strong history of hematologists seeing amyloid patients, and although primarily those are AL amyloid, the hematology group sees all types of amyloidosis. So that was founded by Dr. Bob Kyle, and I worked with him even when I was a medical resident. And then I worked with him on a few papers when I was a fellow, and then Dr. Gertz and Dr. Dispensieri. And Dr. Dispensieri has been a particularly good mentor to me because she helped me learn the nuts and bolts of clinical trials, and she's a fantastic research mentor. And again, we work together with a pretty big group of hematologists and cardiologists now. So I think once we had the cardiac amyloid clinic, it helped us work better as a multidisciplinary team than previously. So in cardiology, Dr. Tajik was my mentor in echocardiography, and he's always been interested in amyloid and published some of the early papers, and always taught us to really be looking for amyloid. Look, for example, if the left heart doesn't look thick, look at the right ventricle. And if he also taught me the posterior wall may often be thicker than the septum, things like that. So he would certainly be a mentor from the imaging standpoint.
Sure. What career advice would you have for young faculty or medical students or residents that are looking to go in, not necessarily just for amyloid, but in terms of how to have a successful academic career, balancing the clinical aspects and work-life balance, all of those things?
Yeah, I think, one of the key things is that it may be hard for them, but you cannot plan this all out. You cannot have this master plan. When I work with the medical students the second year, they're so busy trying to plan everything out. And as you know, we go along through our careers. Maybe we thought we were going to go one way, and then we found something else that interested us. I know it sounds kind of simplistic, but I really do think you have to follow your heart as far as where your interests are. And you have to have some recognition of your abilities. I mean, if you're really not good at procedures, then you're not going to be doing procedure-based practice. And then on the research, I think for all of us, almost any type of practice should have an academic component to it, if at all possible, right? And that can be in many different ways. And for me, for quite some time, it was more, clinical retrospective projects, which I really enjoyed. You can learn a lot of things by looking back at your experience. I put that on hold a little bit when our son was young because I felt like education, clinical practice, research, I wasn't going to be able to be doing a huge amount in every area. So I focused more on clinical practice and education. And then now when I had a little more time after he grew up, then I started doing more of the research, and then in this case the clinical trials came. So I learned both through my mentor and some on-the-job training how you do these clinical trials and all other research projects that we have, and that's really how I was able to develop the cardiac amyloid research program.
I think it's great advice it's hard to tell medical students and residents who are mostly type A, not to plan everything because things will change, but I think it's important advice to.
And I think, one of the things, the work-life balance issue, I'm not a big fan of that work-life distinction. I mean, your life and work are really intertwined, right? And so, if you have a patient that suddenly has an emergency and you're the only one that, can take care of that, that's what you're going to take care of, And the same thing with family things that may come up. I don't really see them as so distinct. I think they're very interwoven. So I usually show the medical students a picture of me up on the beach at our place in Michigan, and I'll say, well, look what I'm reading out there. So it could be, Jack, and it might be, Jace, and, New England Journal, but right in there is, a catalog from this retail store and that retail store, and, those are all intertwined, and that's how the way I think about it. I think it's kind of like saying, do you love your mother or your father more, or something like that. So I think if they're together, then you do have some balance in both of them.
So one thing I didn't realize, after internal medicine, you worked in the federal prison for several years?
Yeah, a lot of people don't know about that one.
Yeah, tell me about that experience. It sounds fascinating.
So when I went to medical school on a National Health Service Corps scholarship, and so that's similar to people that had military commitments. They would support me, and then each year that they supported me, I had a year of service. And that needed to be in some underserved medical areas. So by then I had finished internal medicine, but they don't want people that are subspecialists. They need primary care doctors. So I needed to do my commitment before I could do cardiology. And I wasn't sure if I wanted to do cardiology, actually. So I knew that I had that interest, but I had to fulfill my commitment. So I looked at a lot of different opportunities of where I could go. And in the end, believe it or not, the Federal Medical Center just opened in Rochester, Minnesota, which is a Federal Bureau of Prisons tertiary care center. When I was there, it was literally had just opened. It had been a former state mental hospital that had closed. And even when it was a state hospital, they had a relationship with Mayo. They had operating rooms out there, fellows, and staff would come out and do operations and things. So we had a pretty good physical plant. We literally had a hospital. And then I was involved, and I ended up being the chief of medicine, and then I was a medical director, which when I was a medical director, I was an associate warden. So I was second only to the warden in that. So it was a fascinating thing. I saw a very wide spectrum of disease. I had to learn about things that I wouldn't have been exposed to before. How do we try to prevent a tuberculosis outbreak, things like that. So it was very good. But during that time is when I decided I really wanted to focus on cardiology. So it gave me that extra 3 years to do that. And then then I ended up coming back to Mayo to do my cardiology fellowship.
That's incredible. Did that experience translate into anything later in your career? Did it help you in any way?
I think one of the main things that helped me is that I had practiced general internal medicine, and I also had a lot of administrative responsibilities. So 2 ways it helped me. After I did all that administrative stuff, I should say, when I was there, I had no desire to do that. When I came back, of course I was a fellow, so I wasn't going to be doing a lot, but I wanted to be under the radar. I mean, do not give me these jobs. I just want to see my patients, do my research, do the education. I had no desire to go, I didn't want to be the chair of cardiology or anything like that. Let those other people do that, because I've already seen what that's like.
It's good you had that experience to accelerate that education.
And, because when I was at the prison, the patients by definition were always there. So some of the outpatients had to come to see me at certain times, but the patients that were in the hospital, I could round on them anytime. So I would spend all day going to meetings and doing administrative things, and then I would go round on my patients, get home very late at night. So anyway, I realized that although I had some skills in that area, that wasn't my main goal. So that was good. The other thing I think was that I had been practicing. So when I came back as a fellow, I didn't mind at all having the consultants make the final decision. And in our practice, the consultants are very, very involved in the ultimate decision. So the trainees have an important role, but I actually didn't mind that at all. Okay, you figure out what I know what I'm going to do, what I would do, but it made it a little bit easier to be a trainee. I think some people get tired during the end of their training, but that didn't bother me at all. I was so happy to have somebody else there so that I didn't have to make the final decision on everything. So I think it made being a trainee a little bit easier.
Absolutely, yeah. I mean, that's an early part of your career to have to be the one making all the decisions.
Yeah, it was.
So last question in terms of amyloid. I mean, there's so many new treatments, and just if you can kind of put yourself 20 years, 30 years in the future, how do you think amyloid will be treated? Do you think we'll have cures? Do you think we'll is this the golden age of this era? And is that going to plateau?
Well, I don't know if the way I think that this is not the end, this is the beginning, that's for sure. So I think we will recognize and diagnose patients earlier. Now that we know that the wild-type TTR amyloid is so common, we are going to be finding more AL amyloid. I'm convinced of that. And I think we'll find them earlier and have better outcomes for all types of amyloid. I don't think this is going to be the peak and then the downhill. And I do think, actually, for people looking for career choice, if they're interested in it, it's a great field.
Dr. Grogan, it's been such a pleasure. Thank you so much for
great.
being here.
Thanks so much for having me.
To talk to you.